So there are definitely limitations from a testing standpoint, from a radiology standpoint. Are there limitations from a pathology standpoint? Well, from my perspective, there are. There was a report in the OOO journal last year, Mullen et al., 2015. They looked at 566 consecutive biopsies retrospectively, head and neck pathology, 566 cases, and on review with a second opinion found that diagnosis and management would vary as much as 10% of the time, and that there was a difference between what they had originally called benign and was actually malignant roughly 4% of the time. So we look at pathology as though it's the gold standard, and it may not be. There are certainly some limitations. And when I think about pathology and oral pathology as a whole, I think of it as a second language. It's something that we all were very adept at speaking at some point in our dental training, second or third year, the idea to learn all of this, learn this foreign language so that we could recite it all perfectly and do well on a test, but with maybe little understanding that sometime in our career we would be faced with some of these pathologies, and we may have one chance to get it right, and with that one chance to get it right can have a significant impact in that patient's overall lifetime. So when we look at this particular case, this is a 46-year-old white female. She has a chief complaint of pain in her jaw and a bad taste in her mouth. And there's an ill-defined radiolucency in the 18-19 region. There's no mobility, and both 18 and 19 were non-responsive to all thermal testing. So based on the clinical findings, the diagnosis wasn't really clear. The endodontist was concerned that this was a lesion, maybe a lesion not of inflammatory origin, and he suggested to the patient that she consider having a biopsy, which was done. And here we see the results of that biopsy. There's no inflammation here, but what there is are strands and cords of odontogenic epithelium. I'm trying to get my arrow to come down. Right here. Cords of odontogenic epithelium set in a very dense fibrous connective tissue background. So no inflammation means no periapical inflammatory disease. So the endodontist's suspicion that this was not a lesion of endodontic origin is proved out by the biopsy. But as we look at this biopsy, we're not really sure what this represents. Cutting through it, we see more cords and strands of epithelium in that dense fibrous connective tissue background. And consider that this might be a central odontogenic fibroma, which is uncommon. There are less than 100 cases of central odontogenic fibroma reported in our literature. It occurs over a wide age range and can occur in both the maxilla and mandibular areas. Most often in the maxillary lesions, they are anterior to first molar, mandibular lesions posterior to first molar, so that would fit. Small lesions tend to be asymptomatic, and larger lesions tend to have some bone expansion, maybe symptoms, maybe loose teeth, and that would fit with the demographic as well. Smaller lesions, which is sort of a theme and a trend, smaller lesions tend to be unilocular and well-defined. Larger lesions tend to be multilocular, and that's true of many disease entities. So here we see a central odontogenic fibroma with the odontogenic epithelium, but the connective tissue background in this case is much more loose in this region, just a few strands of the odontogenic epithelium in through here, as opposed to our case, where we see a much more dense connective tissue and fibrous background. And if we look closely at the cells, there's cellular and nuclear pleomorphism and atypia, which is a sign of a little bit more aggressive behavior. So we weren't able to make the call as to what this actually represented, and the pathologist's best friend, when we don't know exactly what we're looking at, is to cut through it and take deeper sections. And on deeper sections, there are some ill-formed duct-like structures in several locations throughout the lesion. And as we continue to cut through and make comparisons, here's a duct-like structure, and the image on the right is an image of metastatic breast cancer. So it doesn't look the same, but there are some similarities, enough where you're concerned that that potentially represents a lesion not of endodontic, certainly not of endodontic origin, but not even of dental origin, that it may represent metastatic breast cancer. Here our lesion is blown up, and we see, again, nuclear and cellular pleomorphism a sign of more aggressive behavior. And as we continue to cut through it, the same sort of thing. But as we cut through now, this is the same lesion. We see these strands that look very much like odontogenic epithelium. So it appears to be that this may be more of an odontogenic tumor rather than a metastatic tumor. But at this point, it's far from certain. So we give so much credibility to the pathology as being the gold standard, but even with good pathology, good staining, and accurate reads, that there can still be significant diagnostic uncertainty. That's the lesion that we're looking at, and this is a classic ameloblastoma where we see the palisading of the nuclei and the reverse polarization away from the basement membrane. So this is classic ameloblastoma on the right. You can see that there's some resemblance to that with our lesion on the left, but it certainly isn't identical. So at this point, the diagnosis is really unclear. There was further consultation done with the oral surgeon, and it was learned that the buccal cortical plate was perforated and there was expansion. And because of this behavior with the cellular atypia, there was significant concern that this could represent a metastatic breast cancer. So further diagnosis and workup was done. The patient had a mammogram, which was negative, a breast biopsy, which was also negative, and CT and bone scans were negative. There was immunohistochemistry done on the lesion, and it was cytokeratin positive, telling us that it's a lesion of epithelial origin. We pretty much know that just by looking at the glass slides. But it was gross cystic disease fluid protein, estrogen receptor, and progesterone receptor negative. So that's pretty much ruling out breast cancer, which is great, but we still don't know what this represents. So it's sent out to other groups, other institutions to look and basically come to a consensus. What does this represent? What do we think the most appropriate treatment might be? The Mayo Clinic called it ameloblastoma, but I think I showed that it had features of ameloblastoma, but was certainly not the classic histopathology of ameloblastoma. It's sent out to other groups as well, and the diagnosis varies from well-differentiated odontogenic carcinoma to something actually malignant ameloblastoma. And of course, my favorite one is on the bottom. Don't know, but let's treat it as ameloblastoma because it has those features. And quite honestly, that is honest. I don't know because we hadn't seen anything like this before. So the idea was to treat it as ameloblastoma, to do a block resection with 1 centimeter margins, and that was done. So we go from that ill-defined interproximal 18-19 radiolucency to this. And this is where the margin looked clean from a surgical standpoint, and the histopathology is done. And now we see, again, another strand of this odontogenic-like epithelium, the dense fibrous connective tissue background, and there's resorption of bone in that region. Here we see a more close-up view of the bone resorption caused by the lesion. And this was basically given a name. It was called sclerosing odontogenic carcinoma. Something that was reported in the American Journal of Surgical Pathology. Basically a name that's a description. What is this lesion? It has the dense fibrous connective tissue background. It's odontogenic in origin, but it's something that we hadn't ever really seen before, and this is 2008. So we're constantly seeing and learning new things, even though we think pathology and biopsy is the gold standard. This is the inferior alveolar nerve. And this is tumor infiltrating the inferior alveolar nerve, which is what we refer to as perineural invasion. And the perineural invasion is a hallmark sign of malignant behavior. Unfortunately, what we also see here is ink at the margin, and that ink at the margin is telling us that this was the resected margin. And because there's ink and tumor present, we know that the margin is not tumor-free. And now the patient is going to require another surgery. She had a second, then definitive, or hopefully definitive surgery that was done with frozen sections. So the tissue was sampled, flash frozen, and immediately looked at to determine if the margin was tumor-free. And once it was determined that the margin was tumor-free, they went 1 centimeter beyond that. And this is where she actually ends up. So again, from that little subtle lesion, interproximal 18-19, this is actually the tumor-free margin. So obviously that's significant disease mimicking periapical pathology. A biopsy is done. The biopsy isn't definitive, so there are many limitations and gaps in what we know and what we can do for certain patients.